and welcome to today's webinar, CDC's Core Elements of Outpatient Antibiotic Stewardship, hosted by CDC. CDC's mission is to protect patients whenever they receive their medical care. My name is Kelly O'Neill, and I'm a Health Communications Specialist leading Antibiotic Stewardship Communications for the Division of Healthcare Quality Promotion at CDC. This webinar is part of a series of infection control-related webinars that CDC hosts along with a variety of external partners and experts. Thank you for joining us today. Today our featured speaker is Dr. Catherine Fleming-Dutra, Medical Officer, having some slide issues. Dr. Catherine Fleming-Dutra, Medical Officer in the Office of Antibiotic Stewardship in the Division of Healthcare Quality Promotion at CDC. She will discuss implementing antibiotic stewardship into your outpatient practice. Before we get started, there are a few housekeeping items to cover. We welcome your questions. Please submit any questions or comments you have via the chat window located on the lower left-hand side of the webinar screen anytime during the presentation. Questions will be addressed after all presentations as time allows. To ask for help, please press the Raise Hand button located on the top left-hand side of the screen. If you need to chat with a meeting chairperson for assistance, such as technical difficulties during the webinar. To hear the audio, please ensure that your speakers are turned on with the volume up. The audio for today's conference should be coming through your computer speakers. In addition, the speaker slides from today's presentation will be provided to participants in a follow-up email. Thank you. Now it's my pleasure to introduce our speaker for today, Dr. Catherine Fleming-Dutra.
Thank you, and thanks for for joining us this afternoon. As far as today's objectives, we will review the importance of antibiotic stewardship in outpatient settings. Then we will identify 4 core elements of antibiotic stewardship across various outpatient settings. And finally, we will discuss evidence-based strategies that can be used to implement the core elements in your practice. So why is antibiotic stewardship so important? It's because antibiotics really are such important medicines. The life-saving benefits of antibiotics in medicine and public health are undeniable. Infectious bacterial diseases that were once deadly are now treatable, substantially reducing deaths compared to the pre-antibiotic era. We should also recognize that antibiotics are an important and crucial adjunct to modern medical advances, permitting surgical and medical treatment for a variety of serious illnesses. Antibiotics are critical tools that help make transplants and cancer chemotherapy possible by allowing us to prevent and treat bacterial infections. Antibiotics really are miracle drugs, and we need them to keep working. And that's why antibiotic resistance is one of the most pressing public health threats of our time. CDC estimates that 2 million illnesses and 23,000 deaths are caused by antibiotic-resistant infections each year in the U.S. And antibiotic-resistant infections cost an estimated $20 billion in excess direct healthcare costs annually. To be very clear, the primary modifiable driver of antibiotic resistance is antibiotic use. To illustrate this, let's walk through a brief timeline of the history of antibiotics. On the top, you can see the year that each of these antibiotics were introduced. And then we can overlay the date that resistance was first identified in select species to each of these antibiotics. And what you can see is that resistance is never far behind the introduction of new antibiotics. Bacteria will inevitably find ways of resisting antibiotics developed by humans, which is why aggressive action is needed now to keep new resistance from developing and to prevent the resistance that already exists from spreading. And that's why we must use antibiotics appropriately. And it isn't just antibiotic resistance that we have to worry about. It's important to remember that antibiotics can also have other unintended consequences, including adverse events. It's really a matter of patient safety. Antibiotic-associated adverse events can range from minor conditions to much more severe. They can cause side effects like rashes and antibiotic-associated diarrhea. and they can cause allergic reactions, including life-threatening ones like anaphylaxis. And 1 in 1,000 antibiotic prescriptions leads to an emergency department or ER visit for an adverse event, which equates to 142,000 ER visits per year for antibiotic-associated adverse events. And this is especially problematic for the pediatric population, as antibiotics are the most common cause of drug-related emergency department visits for children. And there is also emerging evidence of long-term consequences of antibiotic use. Evidence that antibiotics are associated with chronic disease, including allergic and autoimmune diseases, through disruption of the microbiota, the community of microbes living in and on our body, and the microbiome, the collective genes and gene products of that microbial community. Another serious unintended consequence of antibiotic use are Clostridium difficile infections. Clostridium difficile, or C. diff, is a bacterium that can cause very serious diarrheal illness, even life-threatening illness. Taking antibiotics can put people at risk for C. difficile infection. In 2013, the CDC estimated that C. difficile caused at least 250,000 infections and 14,000 deaths in the U.S. each year, leading to an estimated $1 billion in medical costs. And a more recent estimate put those numbers even higher, at 453,000 infections and 15,000 deaths annually in the U.S. And the risk of C. difficile infections and adverse events and the risk of antibiotic resistance, these are all reasons why it's so important to use antibiotics only when they're needed. So why should we focus on the outpatient setting? Antibiotic stewardship programs are traditionally in the inpatient setting. This graph shows antibiotic expenditures in the U.S. by treatment setting, which totaled $10.7 billion in 2009. Of that $10.7 billion, 62% of antibiotic expenditures occurred in the community or outpatient settings, followed by 34% in hospitals and 5% in nursing homes. And remember that most antibiotics used in the inpatient setting are much more expensive than those used in the outpatient setting, and thus the actual volume of antibiotic use in the outpatient setting is likely much higher. Based on data from other developed countries, we estimate that 80 to 90% of human antibiotic use occurs in the outpatient setting, illustrating why outpatient antibiotic stewardship is also critical to combating antibiotic resistance. It's clear that we need to improve antibiotic use across the spectrum of healthcare, and we can't leave the outpatient setting out of those efforts. So do we have room to improve antibiotic prescribing in the outpatient setting? We do. Recently, CDC estimated that at least 30%, almost 1/3 of antibiotic prescriptions written in the outpatient setting were unnecessary, meaning that no antibiotic was needed at all. And even among the, quote, necessary 70%, there are still more inappropriate antibiotic prescribing, including inappropriate antibiotic selection, meaning that the wrong antibiotic may have been chosen, inappropriate dosing, and inappropriate duration, meaning that the antibiotic was given for too long or too short a time. Total inappropriate antibiotic prescribing, including unnecessary antibiotic prescribing plus inappropriate selection, dosing, and duration, is likely much higher. So what is antibiotic stewardship? Antibiotic stewardship is the effort to measure antibiotic prescribing, to improve antibiotic prescribing so that antibiotics are only prescribed and used when needed, to minimize misdiagnoses or delayed diagnoses leading to the underuse of antibiotics, to ensure that the right drug, dose, and duration are selected when an antibiotic is needed. And antibiotic stewardship is fundamentally about patient safety and delivering high-quality health care. Antibiotics are wonderful medicines. They're life-saving. But like all medicines, they have risk and benefits. And to keep our patients safe, we want to make sure that we are using antibiotics appropriately. In 2014 and 15, CDC released the core elements of hospital antibiotic stewardship programs and the core elements of antibiotic stewardship for nursing homes, respectively. These core elements do not include the outpatient setting. And we heard from our stakeholders that there was a need for core elements for outpatient antibiotic stewardship, based on the outpatient stewardship literature, based on what works in the outpatient setting, and that's tailored for outpatient settings. So we heard you, and now we have the core elements of outpatient antibiotic stewardship, which were published in the Morbidity and Mortality Weekly Report, or MMWR, recommendations and reports last week on November 11th. And these core elements provide a framework for improving antibiotic prescribing by outpatient clinicians and within facilities that routinely provide outpatient antibiotic treatment. So who are the core elements of outpatient antibiotic stewardship intended for? They have a broad target audience and are intended for any outpatient clinician, clinic, or health system that is interested in improving antibiotic prescribing and use. These may include primary care clinicians and clinics, outpatient specialty and subspecialty clinicians and clinics, emergency departments, retail health clinicians, dentists, urgent care clinicians, nurse practitioners and physician assistants working in outpatient settings, and healthcare systems that have outpatient facilities. So where do you start? What are the initial steps to implementing outpatient antibiotic stewardship? First, it's important to identify within your practice or clinic what are the opportunities for improvement by identifying the high priority conditions for intervention. So high priority conditions are those conditions within your practice or facility for which clinicians are commonly deviating from best practices for prescribing antibiotics. So some examples of the types of conditions that often lead to inappropriate antibiotic prescribing are conditions for which antibiotics are overprescribed, such as acute bronchitis, a condition for which antibiotics are not recommended but are often prescribed. Conditions which are overdiagnosed, for example, streptococcal pharyngitis, which is sometimes diagnosed in the absence of confirmatory tests, such as a rapid strep test or throat culture. Conditions for which the wrong dose, duration, or agent is selected, such as when clinicians diagnose acute bacterial sinusitis and prescribe azithromycin, rather than amoxicillin or amoxicillin clavulanic acid as recommended by National Clinical Practice Guidelines. Conditions for which watchful waiting or delayed prescribing is underused, such as for acute otitis media in children, and conditions for which antibiotics are underused or the need for timely antibiotics isn't recognized. For example, sexually transmitted diseases in which misdiagnoses lead to undertreatment, or in sepsis in which timely treatment with antibiotics is critical. Next, it's important to identify barriers that lead to deviation from best practices. So barriers to prescribing antibiotics appropriately might include clinician knowledge gaps about best practices and clinical practice guidelines. But deficits in clinician knowledge are seldom the only barrier to prescribing antibiotics appropriately in the outpatient setting. Other barriers to appropriate prescribing include clinician perception of patient expectations for antibiotics, perceived pressure to see patients quickly, clinician concerns about decreased patient satisfaction with clinical visits when antibiotics are not prescribed. Effective antibiotic stewardship interventions need to help clinicians address and overcome barriers to appropriate prescribing. And in order to do so, it's important to understand what those barriers are. And finally, establish standards for prescribing. Standards for antibiotic prescribing can be based on national clinical practice guidelines by national healthcare professional societies, such as the American Academy of Pediatrics, the American College of Physicians, or the Infectious Diseases Society of America, to name a few. Or, if applicable, can be based on facility or system-specific clinical practice guidelines. Establishing standards is really the foundation of deciding what is and what is not appropriate antibiotic prescribing, and clinicians need to know what they're supposed to be prescribing to be able to make improvements. So what are the 4 core elements of outpatient antibiotic prescribing? First is commitment, which means to demonstrate dedication to and accountability for optimizing antibiotic prescribing and patient safety. Next is action for policy and practice, to implement at least one policy or practice to improve antibiotic prescribing, assess whether it's working, and modify as needed. After that is tracking and reporting, which means to monitor antibiotic prescribing practices and offer regular feedback to clinicians or have clinicians assess their own antibiotic use. And finally is education and expertise, to provide educational resources to clinicians and patients on antibiotic prescribing, and ensure access to needed expertise on antibiotic prescribing. So next, I'm going to go through each element in detail, and for each I will describe the element and then highlight interventions aimed at clinicians, including those in small or solo practice, and then interventions aimed at clinic or health system leadership levels. We organize the document in this way in order to make it easier for clinicians in small practices to find those interventions that are pertinent to their setting, and for the leadership of bigger organizations to find those interventions that may need the infrastructure of a larger clinic or system to accomplish. In order to meet each core element, only one suggested intervention needs to be done from either the clinician list or the organizational leadership list. And as I talk about each list, I will talk about the interventions under the clinician section or the organization section. But that being said, we hope that clinicians and health systems will strive to implement many of the interventions over time from both lists, whichever makes the most sense for your practice. So first, commitment, again, means demonstrating dedication to and accountability for optimizing antibiotic prescribing and patient safety. So first, I'll focus on what clinicians can do. Individual clinicians can write and display public commitments in support of antibiotic stewardship. This sounds perhaps a bit corny, but it's actually an evidence-based intervention to improve antibiotic prescribing. So using public commitments is a novel approach to changing prescriber behavior that relies on principles of behavioral science. In a study published in JAMA Internal Medicine in 2014, Meeker and colleagues used a very simple intervention, putting a poster in the exam room with clinicians' pictures and commitments to use antibiotics appropriately. But they did this intervention in a scientifically rigorous way, a randomized controlled trial. They used a principle of behavioral science that clinicians, like all people, want to be consistent with their previous commitments. The poster had the clinician's picture on it and the commitment to use antibiotics appropriately, and they called this a behavioral nudge to make the right choice. They didn't require that antibiotics were used appropriately, but the poster reminded clinicians of their commitment to use antibiotics appropriately at exactly the right time, at the time of the patient encounter. And the poster contained a letter on it, and to highlight part of what it said, it ended with this quote: "As your doctors, we promise to treat your illness in the best way possible. We are also dedicated to avoid prescribing antibiotics when they are likely to do more harm than good." And the amazing thing is that this worked. It actually worked really well. In the poster group, there was a 20% reduction in inappropriate antibiotic prescribing for acute respiratory infections compared to controls, and it was statistically significant. And this is a fairly impressive effect size for improving antibiotic prescribing and at a minimal cost. So the study highlights the importance of recognizing that prescribing is a behavior, and insights from behavioral science are likely to help us change the behavior for the better. And so I hope you'll see this importance in the remaining core elements. And we aren't the only ones that think this is a great intervention. The authors of the poster commitment study have assisted states and clinicians across the country to implement their own versions of this commitment to appropriate antibiotic prescribing, including the Illinois Department of Public Health and Superior Health Plan in Texas in collaboration with the Texas Health and Human Services Commission and Department of State Health Services, and the New York State Department of Health, which is providing commitment posters and encouraging clinicians to sign their Get Smart guarantees. To read more about these 3 examples, please visit our Safe Healthcare blog post listed at the link. And we at CDC would really like to see every clinic use this simple, low-cost, and effective intervention. And CDC also worked with the authors of this study to make a commitment poster that's now available on CDC's website for download. And clinicians can add their signature and pictures and post it in their clinics. So we'll hope that you'll all make a commitment to use antibiotics appropriately by starting with a commitment poster, either by using one of the ones available in your state, making one yourself, or by using the one from CDC. And in doing so, you will fulfill the first core element of outpatient antibiotic stewardship. At the organizational level, in addition to the commitment poster, leadership can also identify a single leader to direct antibiotic stewardship activities within a facility. They can include antibiotic stewardship-related duties in position descriptions or job evaluation criteria, which will help ensure staff members have sufficient time and resources to devote to stewardship. And they can communicate with all clinic staff members to set patient expectations. Patient visits for acute illnesses might or might not result in an antibiotic prescription. And all staff members can improve antibiotic prescribing by using consistent messages when communicating with patients about the indications for antibiotics. Action means implementing at least one policy or practice to improve antibiotic prescribing, assess whether it's working, and modify as needed. So we have included a lot of examples of actions, but again, I want to stress that the core elements are about implementing at least one. So don't feel like you need to start with all of these. As with all quality improvement initiatives, it's best to implement these elements in a stepwise fashion. Implement an action, assess whether it's working, and then modify it if needed. Individual clinicians can implement at least one of the following actions. Use evidence-based diagnostic criteria and treatment recommendations based on national or local clinical practice guidelines. And clinicians can also use delayed prescribing practices or watchful waiting when appropriate. Delayed prescribing can be used for patients with conditions that usually resolve without treatment, but who can benefit from antibiotics if the conditions do not improve. Examples of conditions for which national clinical practice guidelines support the use of delayed prescribing or watchful waiting include acute uncomplicated sinusitis or mild acute otitis media in children. And we at CDC know that it can be challenging to keep up with the national clinical practice guidelines from all of the various professional societies. So on our website, we have consolidated and summarized the treatment recommendations for adults and children for common outpatient infections, as well as provided the references and links to the national guidelines. So please check out this site for an easy summary of these guidelines. For the organizational leadership, actions may also include providing communication skills training for clinicians, requiring explicit written justification in the medical record for non-recommended antibiotic prescribing, providing support for clinical decisions, and using call centers, nurse hotlines, or pharmacist consultations as triage systems to prevent unnecessary visits. More information about all of these interventions, including the references for the supporting evidence for these interventions, are contained in the core elements document. But I want to take a minute to highlight one of these actions, communication skills training. So communication training is actually an effective antibiotic stewardship intervention. Studies using enhanced communication training have reduced inappropriate antibiotic prescribing for respiratory infections while maintaining patient satisfaction. And the communication trainings reviewed a number of goals for each visit, including understanding the patient's expectations, explaining why antibiotics will or will not help, providing symptomatic treatment recommendations so that the patient can feel better, discussing when the patient should return or call back if the patient is not better. And the effect of these trainings was sustainable over time. In one study, improvements in antibiotic prescribing persisted 3.5 years after the communication training occurred. So based on the evidence, training clinicians to communicate effectively about antibiotic prescribing is an important stewardship intervention. So we hope that you will train your clinicians how to approach these very common visits so that they can prescribe antibiotics appropriately and maintain patient satisfaction. Next is tracking and reporting clinician antibiotic prescribing, also called audit and feedback, which means to monitor antibiotic prescribing practices and offer regular feedback to clinicians. For individual clinicians, this will likely mean self-evaluating their own antibiotic prescribing practices to make sure they align with updated evidence-based recommendations and clinical practice guidelines. And one way to do this is to participate in continuing medical education and quality improvement activities that incorporate tracking and improving antibiotic prescribing practices into these activities. These activities may be available through professional societies and may be used to meet licensure or other educational requirements. At the organizational level, this means implementing at least one antibiotic prescribing, tracking, and reporting system. It can also mean assessing and sharing performance on quality measures and establish reduction goals addressing appropriate antibiotic prescribing. So for example, 3 current healthcare effectiveness data and information sets, or HEDIS measures, that are often tracked by health plans and payers include quality measures addressing appropriate antibiotic prescribing. These are appropriate testing for children with pharyngitis, appropriate treatment for children with upper respiratory infections, i.e. avoidance of antibiotics, and avoidance of antibiotic treatment in adults with acute bronchitis. So organizations can report clinician performance on these measures back to clinicians as part of a tracking and reporting system. So what should you track and report in your outpatient facility? Outpatient clinicians and clinic or health system leaders can select outcomes to track and report on the basis of identified opportunities for improvement in their practice or clinics. We really meant this document to be flexible so that it can apply to a variety of outpatient settings. Systems can track high-priority conditions identified as opportunities to improve clinician adherence to best practices and clinical practice guidelines. So, for example, acute bronchitis is a common condition for which antibiotics are not recommended in national clinical practice guidelines, yet antibiotics are commonly prescribed. Therefore, leaders might choose to provide feedback on the percentage of acute bronchitis visits in which a clinician prescribes an antibiotic and include comparisons to their peers' prescribing percentages for acute bronchitis. Systems can also track the percentage of all visits for which an individual clinician prescribes antibiotics, meaning the number of all antibiotics prescribed for all diagnoses by that clinician divided by the total number of visits for all diagnoses by that clinician. And also, certain healthcare systems might be able to track and report the complications of antibiotic use, events like adverse drug events and Clostridium difficile infections. And they can also track antibiotic resistant trends among common outpatient bacterial pathogens. However, it's important to note that at the individual or clinic level, smaller sample sizes might make these measures based on adverse events and antibiotic resistance less reliable. So it's important to understand that effective feedback interventions have included comparisons of clinicians' performance with that of their peers. Examples of studies that use peer comparisons include a study that sent regular reports comparing antibiotic selection patterns of clinicians with their colleagues' mean performance. This led to improvements in use of guideline-recommended antibiotic agents for common outpatient conditions, including acute bacterial sinusitis. Another study compared clinicians' percentage of inappropriate prescribing for acute respiratory conditions to top performers in their practice. And top performers meant clinicians who were performing in the top 10% or had the least amount of antibiotic prescriptions for acute respiratory infections that did not warrant antibiotics, such as colds and bronchitis. In this study, the top performers had 0 or no unnecessary antibiotic prescriptions for acute respiratory infections that didn't warrant antibiotics. And this peer comparison intervention led to decreased inappropriate antibiotic prescribing for acute respiratory infections that should not be treated with antibiotics, again, like colds and acute bronchitis. Another study conducted in the National Health Service in England looked at the percentage of all visits leading to antibiotic prescriptions and notified clinicians who prescribed more antibiotics than 80% of their peers. They sent a letter to those clinicians from the Chief Medical Officer of the National Health Service that said, quote, "The great majority, 80% of practices in your area prescribe fewer antibiotics per head than yours," end quote. This intervention led to decreased overall antibiotic prescribing and to cost savings. From these studies, we can see how important peer comparisons are to include an effective tracking and reporting system, and we hope that you will include peer comparisons in your tracking and reporting systems. And finally, education and expertise, which means to provide educational resources to clinicians and to patients on antibiotic prescribing and ensure access to needed expertise on optimizing antibiotic prescribing. Clinicians can educate their patients and their patients' families about appropriate antibiotic use. To do so, they can use effective communication strategies to educate patients about when antibiotics are and are not needed. They can educate about the potential harms of antibiotic treatment, including both common and serious side effects of antibiotics, C. difficile infection, and antibiotic resistance. And they can provide patient education materials that include information on appropriate antibiotic use, potential adverse drug events, and available resources regarding symptomatic relief for common infections. So I want to again highlight the issue of communication. In this sense, educating patients through effective communication. We talked about how communication training can be an action for policy and practice. Clinicians themselves can then use effective communication strategies as a way to fulfill the education and expertise core element. And we very purposely highlighted the importance of communication in 2 different places as a way to fulfill the core elements because it is an evidence-based strategy to improve antibiotic prescribing. And it really gets back to understanding the barriers that prevent clinicians from prescribing antibiotics appropriately and helping clinicians address those barriers. We know that clinicians cite patient demand for antibiotics and concerns about patient satisfaction as a reason they prescribe inappropriately. It turns out patients rarely overtly request antibiotics, and clinicians aren't actually very good at determining which patients want antibiotics. But if the clinician thinks the patient wants antibiotics, they're more likely to prescribe antibiotics. So there is an element of miscommunication between clinicians and patients that is contributing to inappropriate antibiotic prescribing. And this is where effectively communicating with patients and educating patients can really help. And patients really can be satisfied without antibiotics, even if they expect them, if the clinician can effectively communicate with them. So a couple of communication techniques have been shown to be effective. First, combining explanations of why antibiotics are and are not needed with recommendations for managing symptoms have been associated with increased visit satisfaction. And by this we mean educating the patient why they don't need antibiotics, especially discussing what they see on physical exam or in the evaluation that shows that antibiotics aren't needed. And then also providing those recommendations of what they can do to feel better. And then providing recommendations of when to seek medical care if the patient worsens or doesn't improve, also called a contingency plan, has been associated with increased satisfaction for patients who expected but did not receive antibiotics. And by this we mean giving specific messages, such as, if you develop a fever or you're not better in a week, call and come back and see me. So communication can help clinicians provide quality care to patients, use antibiotics appropriately, and maintain patient satisfaction. And that's why we hope that clinicians will use effective communication strategies to educate their patients about when antibiotics are and are not needed. At the organizational level, outpatient clinics and healthcare system leaders can provide education to clinicians and ensure access to expertise. When approaching educational interventions, it's critical to understand that in the outpatient setting, inappropriate antibiotic prescribing is rarely due to knowledge gaps alone. Educational strategies need to be grounded in helping clinicians address the barriers that lead to prescribing antibiotics inappropriately. So education can include providing face-to-face educational training, also called academic detailing, providing continuing education activities for clinicians. And relevant continuing education activities include those that address appropriate antibiotic prescribing, adverse drug events, and communication strategies. And also by ensuring timely access to persons with expertise. So what do we mean by this? Expertise in optimizing antibiotic prescribing may come from pharmacists who can help clinicians optimize antibiotic dosing and selection and advise clinicians on medication interactions. In hospitals, pharmacists with infectious disease training have been effective and important members of antibiotic stewardship programs. Access to expertise might also mean having access to a dentist to manage dental conditions that need procedures rather than antibiotics, or to a surgeon, or to an infectious disease physician. The expertise needed will likely differ among outpatient facilities and can be determined by each facility. So where can you find information to educate patients and providers? There are many great resources, from professional societies, from healthcare systems, from many places. But I hope you'll go to our website for some of those resources. We are the Get Smart Know When Antibiotics Work program, and our campaign focuses on increasing awareness about antibiotic resistance and the importance of appropriate antibiotic use among healthcare providers and the general public. Our website has lots of information, resources for patients and healthcare professionals, partners, and information about Get Smart About Antibiotics Week 2. So please check it out, and we hope you find it useful, and you're welcome to use our materials, and we hope you will as part of your educational programs. This year we have some new materials for Get Smart About Antibiotics Week. We strive to update and add materials every year. So for example, we have patient-focused information this year that's new on delayed prescribing and watchful waiting that you can share with your patients. We have a new fact sheet on ear infections, how they're treated, and also includes information on preventing ear infections and on watchful waiting for ear infections. And for more resources, please visit our website for the core elements, which has links to the document, to checklists about implementing the core elements, and to other resources that can help you implement the core elements. And we will continue to build this website out as more resources become available. And also feel free to check out this Medscape video on the core elements of outpatient antibiotic stewardship as well. And finally, the importance of antibiotic stewardship has risen to national prominence and actually international prominence. President Obama has issued a presidential proclamation declaring this week Get Smart About Antibiotics Week. And I encourage you to go look at the link here. So in summary, antibiotic resistance is a major public health threat. And antibiotic stewardship is one of the most important strategies to combat antibiotic resistance and to keep our patients safe. The core elements of outpatient antibiotic stewardship provides a framework for improving outpatient antibiotic prescribing. And to remind you, the core elements include the following: commitment, demonstrate dedication to and accountability for optimizing antibiotic prescribing and patient safety, action for policy and practice, to implement at least one policy or practice to improve antibiotic prescribing, assess whether it's working, and modify as needed, tracking and reporting, monitor antibiotic prescribing practices, and offer regular feedback to clinicians or have clinicians assess their own antibiotic use, education and expertise, provide educational resources to clinicians and patients on antibiotic prescribing, and ensure the needed expertise on antibiotic prescribing. So we can all be antibiotic stewards, and we hope that you will all implement the core elements in your outpatient practice. And so, of course, this was the work of many people, and I want to make sure to thank my co-authors, including Memo Sanchez, Becky Roberts, and Lori Hicks. And I also want to thank those who gave us feedback on this document, including John Finkelstein, Jeff Gerber, Adam Hirsch, Dave Jens, Jeff Linder, Larissa May, Dan Merenstein, Katie Suda, and Rachel Zetz. To our awesome communications team who provided feedback and tons of support and many of the accompanying materials, Kelly O'Neill, Austin Dukes, Rachel Robb, and Meredith Reagan. Thanks to Jackie for organizing the logistics today. And thanks you to all of you for listening and for all the great work that you're doing. I encourage you to visit our website, and I'm happy to take questions now. And if you have questions that come up in the future, please feel free to email us at getsmart@cdc.gov.
Great. Thank you, Dr. Fleming-Dutra, for your time today in explaining this important topic. We've received quite a few questions, so we will do our best to answer as many as possible in the next few minutes. Thank you for chatting in your questions today, and don't forget, if you have a question, please add it to the chat box on the lower left-hand side. So let's see what this chapter. And one of our first questions is, most physicians I work with prefer to prescribe the antibiotic without doing any lab testing to confirm diagnosis. Could a complete blood count or culture be utilized prior to prescribing antibiotics?
Thank you for that question. So I think it depends upon the clinical situation. Certainly, if you're concerned about sepsis, blood cultures, cultures of other sites in the body, complete blood count, and many other lab tests are very important prior to prescribing antibiotics. Other conditions don't require a CBC prior to prescribing antibiotics, such as strep pharyngitis. If the rapid strep test is positive, there's not a need in many circumstances for a backup culture. There's not a need for blood work. So it really depends upon the clinical situation. And for those types of things, again, we encourage you to follow your the national clinical practice guidelines or local or facility-specific clinical practice guidelines.
Okay. Thank you. So the next question is, please differentiate between microbiome and microbiota. Is this a concept that's needed to be taught to patients and clients?
Great. Thank you for that question. So the definition, as I understand it, although I'm not the expert on microbiota and microbiome, but the definition as I understand it is that the microbiota are really the community of microbes living in and on the body. That includes bacteria, but it also includes viruses and other microorganisms. And the microbiome really means the collective genes and gene products of that microbial community. So obviously these are very intertwined concepts. So this is, in regards to the second part of the question, this is a complicated thing to explain to patients, but I think it is an important one. We are just really starting to understand the importance of the microbiota and the microbiome to the development of the immune system, to everything that we do, to the functioning of our bodies, to protecting us. And patients need to understand that antibiotics may have long-term consequences and that disruption of the microbiota is not necessarily a good thing, and that's one of the reasons that we want to use antibiotics only when they're needed.
Great, thank you. So next question, can you address how immunizations can be part of these sorts of initiatives?
Great question. Immunizations are a very important part of combating antibiotic resistance and using antibiotics appropriately. Really one of the things that we can do to prevent the inappropriate antibiotic use is to prevent the infection in the first place. And so, for example, the pneumococcal conjugate vaccine is a great example of a vaccine that has prevented many infections in children and adults and helped reduce antibiotic resistance by preventing these infections and the spread of these infections. And additionally, influenza vaccine is another vaccine that can really improve antibiotic use. If patients don't get sick with influenza, they don't present for care, and they're less likely to get an antibiotic unnecessarily. They're also less likely to get a secondary bacterial infection associated with influenza. So vaccinations are a very important part of keeping us healthy and combating antibiotic resistance.
Great, thank you. Next question, is antibiotic stewardship part of the standard curriculum in medical schools throughout the country that you're aware of?
I'm going to actually let Dr. Lori Hicks, who's the director of the Office of Antibiotic Stewardship, answer some of these questions, so she'll take that one.
So this is Lori Hicks, and I would like to let you know, and for those of you who are not aware, that there is a medical school curriculum that is actually available online. It's through Wake Forest University and was developed in collaboration with folks from the Infectious Disease Department at Wake Forest University, and CDC reviewed the curriculum. It is not a requirement. However, we certainly are encouraging medical schools to incorporate this curriculum or their own content related to improving antibiotic use if there is availability in their curriculum to do so.
And actually, one more question, Lori, for you while we have you. Someone had a question about, unlike inpatient and long-term care stewardship, outpatient stewardship has a stronger patient stakeholder effect. Will there be some form of outreach to the public at large to increase public awareness by CDC through various public media?
So I'd like to just state that actually that's one of the major goals of Get Smart About Antibiotics Week, which is actually this week, as Catherine mentioned, this week, the 14th through the 20th. And our goal is to reach the general public as well as providers and all of our partners to improve knowledge around antibiotic resistance as well as antibiotic use. In addition to that, CDC has a long-standing campaign, the Get Smart Know When Antibiotics Work campaign, and Catherine suggested that you look at our campaign website to access resources for patients. And undoubtedly, we have to address all facets of the prescribing problem, and that includes addressing the patient demand aspect of it as well.
Great, thank you, Lori. Let's see, for our next question, is there any sort of benchmarking data available, or is there a reporting system or tool available to clinicians' facilities to track and report such data?
So there are a couple of different data systems that we use here at CDC to track national antibiotic prescribing practices in the outpatient setting. We do look at proprietary data that is dispensing data from U.S. pharmacies that really gives us a complete picture of the amount and types of antibiotics that are being dispensed in the outpatient setting. That being said, it doesn't come with indications or diagnoses, so it's somewhat hard to assess appropriateness, but we can see in that data that there is substantial geographic variation that really suggests an appropriate use of antibiotics in certain parts of the country. Additionally, there are some national surveys that are run by CDC for which we can look at appropriateness of antibiotic prescribing in the outpatient setting. These surveys look at doctors' offices and emergency departments, and we recently used that survey to estimate that 30% of outpatient antibiotic prescriptions in those settings were unnecessary. And then we encourage health systems and clinics to look at your own data and your own EMRs to look and assess appropriateness of antibiotic prescribing, and then also to use the HEDIS measures and other quality measures available through the CMS MIPS program and other programs like that to track performance on the measures that are associated with appropriate antibiotic prescribing, and that can be leveraged by clinicians, clinics, health systems to look at their own data and to measure improvement.
Great, thank you. So 2 questions related to pharmacists next. Would a pharmacist be an acceptable leader for outpatient stewardship in the facility setting?
Absolutely. I think that what we're looking for is a leader in the outpatient facility setting who understands outpatient stewardship, that understands outpatient medicine and is excited about this. And if a pharmacist is available, I think they would be an outstanding leader for that activity in outpatient settings. They've been outstanding leaders and contributors to inpatient stewardship. So we would love to see pharmacists step into that role if that's something available in your clinic or practice.
And then a follow-up question to that, are there initiatives to have retail pharmacies be proactive in antibiotic stewardship that you're aware of?
That's a great question. So the Get Smart program has long reached out to pharmacists, both clinical pharmacists and retail pharmacists. Pharmacists certainly, they often see the patient before they ever come in for care to a doctor or another provider. They can help recommend symptomatic treatment to patients presenting in retail pharmacies. They can also help educate patients when they receive an antibiotic prescription about adverse events, about taking the antibiotic correctly and disposing of any leftover antibiotics as well. So we think retail pharmacists are a very important part of outpatient stewardship.
Wonderful. So next question, are you developing a curriculum for enhanced communications training or other resources out there to help clinicians with that communications training?
Great, that is a great question. There are a couple of resources out there for communications training and communication skills. We hope to have those posted on our website, linked from our website. They're not our resources, but some good ones that we'll have linked on our website soon. There was a recent skills training that was funded by the Robert Wood Johnson Foundation from Cognito that worked on communication skills, and you can actually play the role of provider or patient in a conversation about antibiotics. Also, the New York State Department of Health put out a video this week talking about communication around this very issue, and it was really well done, and we're excited to be able to provide those resources as well from our website hopefully soon.
Wonderful, thank you. And then a follow-up to this one, since clinicians are often limited with how much time they can spend with a patient, how would you overcome this barrier to taking the time to educate patients about why antibiotics aren't needed?
That's a great question, and clinicians do cite concerns for time as a reason they prescribe antibiotics inappropriately. They sometimes think it's easier to prescribe the antibiotic and not fully explain things, but patients really want communication whether or not they get an antibiotic. That's what they really want from their clinicians, and it doesn't take that long to give them that message. And I would argue, and I think many people would argue that that's part of good patient care, regardless of the treatment plan that you're providing. So there are ways to give those messages in short and succinct ways that don't add much time to the visit, but also help maintain satisfaction. And we have many materials on our website that can help clinicians with those types of education that they can also provide patients.
And this is Laurie, because I just would add to that one of the resources that Catherine was alluding to on our website is a prescription pad for symptomatic therapy. And it may just be that the provider is recommending a humidifier, for example, lozenges for a sore throat, but it provides something for the patient to do, and the patient feels like they have some instructions for steps that they can take to feel better.
Great, thank you. So our next question, how useful are antibiograms in guiding the primary physicians on which antibiotic to use, and should local data be used?
That's a great question. Thank you for that. So antibiograms can be very helpful in helping physicians determine what the appropriate antibiotic selection for particular diagnoses are. So for example, for urinary tract infections, it's very important to know what the local resistance patterns for urinary pathogens are. One important piece of getting the correct antibiogram and having that antibiogram be useful is to make sure that it's pertinent to your setting and that it's local. So if you're in a primary care office, you don't want to be looking at the hospital's ICU antibiogram, but really looking at outpatient primary care antibiograms. But they're critical pieces in informing appropriate antibiotic selection, and many of the national clinical practice guidelines recommend consulting your local antibiograms.
Great, thank you. Next question. So regarding tracking and reporting, who is the appropriate person to manage this, and how much time and resources need to be allocated to properly implement a tracking and reporting system?
So that is a great question. I think there are multiple people that could potentially be managing this. It can be the medical director of the clinic. It can be a nurse administrator or other administrator. It could be a pharmacist. Within a health system, it could occur much more centrally within that health system. It could actually be the clinician that is doing it within their own practice. It certainly could take a lot of time if there's not an automated way to do that in the electronic record. But then we hope that for those clinics where that might be more difficult, that you could potentially utilize the HEDIS measures or other quality measures to start that piece of tracking and reporting as well. And it could also be done manually with, for certain diagnoses or for a certain number of charts per day.
Great, thanks. Let's see. So we probably have time for about one or two more questions before we just need to wrap up. So here's another question. Do you anticipate an increase in resource requirement at the outpatient facility level for implementing policies, actions, education, and monitoring? If so, how is this plan to be managed?
I think that's a great question. I think that, certainly with all quality improvement initiatives, there certainly is an investment of time and resources that are needed. We hope that this document is flexible. We hope that it provides a range of different options that some of which are relatively easy, such as the commitment poster, to things that require a bit more infrastructure. But we hope that it provides a range of options that fit many different settings. But again, this is really about patient safety and about high-quality health care, and antibiotic resistance is one of the most pressing public health threats of our time, and outpatient antibiotic use is the majority of antibiotic use in humans in the United States. And so we really need to focus on this to keep these important life-saving medicines working for our patients.
Great, thank you. Here's another question. Do you think antibiotic stewardship will become a core measure in the outpatient setting as it has in the inpatient setting?
So this is Laurie Hicks, and I would say that we are seeing increasing interest in incorporating stewardship into policies that would help encourage its implementation in outpatient settings. And I just want to include a couple of examples. For example, we have been having discussions with the Joint Commission about opportunities to incorporate the core elements into joint commission requirements for outpatient settings. We've also been talking to payers like CMS as well as private payers about the opportunity to incorporate antibiotic stewardship, outpatient antibiotic stewardship initiatives into their activities. So I think you should anticipate that this will be of increasing interest to both payers, policymakers, and even some of our state health departments and I would say state policymakers are encouraging stewardship activities in all healthcare settings.
Great, thank you, Lori. I think we have time for one more question. So let's see if we have one here. Here's one final question. Okay, Catherine. Are there any public education tools for citizens who are holding on to unused, partially used, or old antibiotic prescriptions at home?
Thank you for that great question. There was actually a recent study that shows that a number of people are holding on to antibiotics at home or sharing antibiotics or doing the things that we hope that they would never do. So certainly pharmacists are a great resource for discarding all leftover medications, including leftover antibiotics. And so we would encourage both clinicians when they prescribe antibiotics, pharmacists when they dispense antibiotics, and public health is, and we have some of this information on our website as well to encourage patients to discard any leftover antibiotics, not to share them, not to save them for next time, and never to take an antibiotic that was not prescribed for them.
Wonderful. Thank you, everyone, for chatting in all your questions today. That's all the time we have for answering these inquiries. But please stay tuned for a follow-up email that will include the slides from today's webinar. So we'll be sending out the slides following this presentation. And then one final plug for Get Smart Week. We just wanted to remind everyone it is Get Smart Week, and we still have a couple ways that you can be involved with the week, including on Friday we have a global Twitter chat from 11 a.m. to 1 p.m. Eastern using the hashtag antibiotic resistance. And then definitely check out our Safe Healthcare blog for a couple blogs this week related to stewardship. And then we also have some new data sets available on our antibiotic resistance patient safety atlas on outpatient antibiotic prescriptions and also the percentage of antibiotic stewardship programs in hospitals. And then we've also included a link here to where you can check out all of our Get Smart Week promotional materials. And lastly, before we finish up today, to receive continuing education credit for this webinar, you must complete and pass the post-test activity at 75% and complete the webinar evaluation. So when you close out of this webinar, a post-meeting webpage will pop up that will have detailed instructions for completing the CE post-test and evaluation. So please be sure to fill that out. And for those on the phone who currently aren't logged into ReadyTalk online, in order to obtain the CE credit, please go to www.cdc.gov/TCE online and then enter in the access code for this webinar, which is WC1115. And just to say that one more time, the access code is WC1115. And then a follow-up email will also be sent out this afternoon with detailed instructions on completing the CE post-test and evaluation. And with that, we'd like to thank Dr. Fleming-Dutra for talking with us today and for all of you for your time, and also Dr. Lori Hicks for helping answer some of your great questions. And that is all we have for you today, so thank you. Oh, and again, sorry, the website to access the post-test is www.cdc.gov/TCE online, and the access code is WC1115. Thank you.